This is a brief vodcast about decisional capacity and informed consent, especially as they relate to palliative care. I'm Susan Merrill. I'm a general internist and geriatrician practicing at the UW and on the Harborview Palliative Care Consult Service. The objectives of this vodcast are as follows: to review the importance of decisional capacity in palliative care, to describe the 4 abilities related to decisional capacity, otherwise known as decision-making capacity and abbreviated as DMC, and to describe important elements of informed consent, including the process to go through when a patient lacks DMC. Why is this important to learn about as a palliative care provider? First of all, we are often helping patients make important decisions about end-of-life care, so we must be sure that they are legally and ethically able to make their own decisions. Second, lack of decisional capacity is both common and under-recognized. Studies suggest as many as 25% of medicine inpatients lack decisional capacity, and 45% of nursing home residents lack decisional capacity. Furthermore, studies suggest that physicians miss decisional capacity in 40% of cases. So we're missing 40% of cases. I also wanted to bring your attention to this very interesting retrospective study done by Mark Zaros and Randy Curtis from Harborview. They looked at patients with advanced cancer who died at the University of Michigan Hospital. 79% of these patients had decisional capacity on admission, but 40% lost decisional capacity during this terminal hospitalization. Those patients who lost capacity and had a surrogate make decisions had more aggressive care prior to death, including more ICU care, more mechanical ventilation, more chemotherapy, and more artificial nutrition. So if we are able to assess decisional capacity and help decisional patients make end-of-life decisions earlier during a hospitalization, before they lose decisional capacity, it may actually change outcomes. Now, defining some terms. Decisional capacity is the ability to accept or refuse care, essentially the ability to provide valid, informed consent. It is closely related to, but not the same as, competency. Decisional capacity is determined by clinicians at the bedside, while competency is only decided in court. Informed consent is acceptance of a medical intervention after disclosure of the nature of the intervention, risks and benefits, and alternatives with their risks and benefits. Informed consent must have 3 elements in order to be considered valid. The patient must have decisional capacity, the decision must be voluntary, and enough information must be given that a reasonable person could make an informed choice. There are essentially 3 situations in which you don't need the patient's formal informed consent for treatment: in life-threatening emergencies, when the patient lacks decisional capacity, in which case you must get consent from a surrogate, and when a patient refuses to provide consent, preferring that a surrogate make the decision for them. As you know, preferences about medical decision-making differ across families and cultures, and there are certainly patients who defer to others for their decision-making. We should support that. So how do we assess decisional capacity at the bedside? We use 4 abilities related to decisional capacity, first described by Applebaum and Grisso in the New England Journal of Medicine in 1988. The 4 abilities are as follows. Number 1, the ability to communicate a choice. Number 2, the ability to understand one's condition and propose treatment. Number 3, the ability to appreciate a situation and its consequences. And number 4, rational reasoning, the ability to demonstrate a thought process that we can recognize as rational, even though we don't necessarily need to agree with it. Just to reiterate, that's communicate a choice, understanding, appreciation, and rational reasoning. Communicating a choice and demonstrating understanding of a proposed treatment plan are relatively straightforward. Appreciation is a higher level ability involving an understanding of the consequences of a decision, with a sample statement indicating appreciation shown here. Reasoning requires some illustration of a rational thought process, although it does not need to be one that everyone would agree with, and I've given some samples here. The process of assessing decisional capacity is actually quite straightforward. You just have a conversation with the patient about the decision and ask them questions that will help you determine whether they have the 4 abilities. Table 1 in the review article by Applebaum that I've assigned summarizes the 4 abilities related to decisional capacity and some suggested questions to ask the patient to assess each ability. 2 important notes here. Decisional capacity is temporal, meaning that the patient can have it and then lose it, for example, if they become delirious. It's also decision specific, meaning a patient can have it for a simpler decision like choosing a surrogate and not have it for a more complicated decision like deciding between 2 complicated kinds of treatment with different risk-benefit ratios. A note here on values. It's really important to know the patient's values and how they've lived their lives and made decisions in the past. While this is not included in the 4 abilities and may not be part of the official or legal definition, it's really important in helping the patient and/or surrogate reach a decision that makes sense for the patient as a person. If a patient does not have decisional capacity, their surrogate will need to officially make the decision. I've included the list of legal surrogates both for Washington State and for the VA system, which has a different list. As you've discussed in your ethics session, the main principle of surrogate decision-making is substituted judgment. That means the surrogate should be making the decision they think the patient would make if they still had capacity. Thank you for your attention.